Thank you for joining today's Cost Measure Field Testing webinar. The purpose of this webinar is to provide information about the field testing of two episode-based cost measures before their consideration for potential use in the cost performance category of the merit-based incentive payment system of the Quality Payment Program. I will now turn it over to Ray DeSaltis from CMS to start the presentation.
Thank you, and hi everyone. My name is Ray DeSaltis, and I'm the MIPS Cost Measure Lead from the Centers for Clinical Standards and Quality at CMS. And I'm going to go through a few slides for our introduction before handing it over to the measure development contractor. This is just a blanket disclaimer about this presentation and general summary and a reference document for stakeholders. So next slide, please. Okay, so today we will provide an overview of the cost measure development process and measure construction, the two episode-based cost measures being field tested, the materials and activities that are part of this year's field testing, and then finally we'll walk through an example of the field testing report. And then at the end of the presentation, we'll have time for questions as well. Next slide, please. Here are just a few acronyms that we use throughout the presentation that may be helpful for reference or when you're viewing the presentation at home. Next slide, please. Okay, so to begin, I will provide some information about the field testing, of what field testing is, and as well as some background on the MIPS cost measures. Next slide, please. So there are currently two episode-based cost measures in development. The measure development contractor Acumen uses a process based on cycles or waves of developing a number of cost measures at the same time. So the current wave of development is the sixth set of episode-based measures, and they cover a range of clinical areas, settings, and conditions that reflect both agency priorities and measurement needs in MIPS. And so the two measures listed here, the movement disorders and non-pressure ulcers, began development last year as part of Wave 6. Both measures assess the outpatient treatment and management of specific conditions, often over an extended period of time. These measures are now fully drafted and undergoing field testing. I just want to stress that these measures are still in development and testing stages and are not currently in the MIPS program. They do not have any impact on MIPS scores. And so after the development process wraps up later this year, CMS may consider these measures for future use in MIPS as part of the cost performance category. Next slide, please. So what is field testing? So field testing is an opportunity for any stakeholders to learn about and provide feedback on the draft measure specifications of episode-based cost measures currently under development. Field testing is currently taking place over 4 weeks. It started on February 1st, and it will end on February 29th. During this time, clinicians and clinician groups will be able to access field test reports in the QPP website, which describe their performance on the measures as currently specified, if they have at least 20 episodes of any of the measures. All stakeholders will be able to review draft measure specifications and testing results on the cost measure information page. Any individual or organization can submit feedback online via an online survey about any aspect of the draft measures. There are separate surveys that focus on the measure specifications and lived experiences with the clinical topics being measured. And the surveys really provide a jumping off point for feedback, but stakeholders can provide comments on any aspect of the measures. All feedback that we receive will be considered in the next steps of wrapping up measure development. So feedback received prior to the end of field testing, February 29th, will be considered in upcoming work group meetings and public comment summaries. And you can also submit feedback after the field testing deadline, though we can't guarantee that it will be incorporated into the meetings or the summaries. Next slide, please. Now I will provide just some context on the MIPS program and where these measures could be used in the future. So the Quality Payment Program has 2 tracks for clinicians to choose from. We We have advanced alternative payment models and MIPS. Clinicians who participate in MIPS have their performance assessed across 4 categories. They are quality, cost, promoting interoperability and improvement activities. A clinician's performance score for each category is rolled up to a MIPS final score, which then determines your payment adjustment. Each of the MIPS performance categories has a weight assigned to it. So the weight of the MIPS cost performance category has increased incrementally over time. 2017 was the first year of MIPS, and the cost performance category was 0%. In 2020 and 2021, the cost performance category was set to 15% and 20% respectively, but they were reweighted to 0% and redistributed to other performance categories due to the impact of COVID-19. Since 2022, the cost performance category has been set to 30% of the MIPS final score, which is required by statute. For 2024, the cost and quality performance categories are equally weighted at both 30% each. And next slide, please. So within MIPS, there are different participation options. Traditional MIPS continues to be an option, but there is also a new participation framework called MIPS Value Pathways, or MVPs, which were available since 2023. So MVPs are a way to connect the quality, cost, and improvement activity categories while maintaining the PI category, as well as population health measures in the foundational layer across all MVPs. The goal of the MVPs is to simplify participation in MIPS and to provide clinicians with a set of aligned measures across performance categories that are meaningful to their care practice. MVPs are required to include at least one cost measure, so this ensures that the value of care, or in other words, the health outcomes for a given cost, can be assessed. If the measures currently being field tested were to be used in MIPS sometime in the future, then they could also be considered for inclusion in MVPs to enhance the way that we assess value or allow new MVPs to be created. And next slide, please. And so the cost performance category is calculated as an average of all cost measures that apply to a given clinician or clinician group. For traditional MIPS and MVPs, the cost measures are automatically calculated using administrative claims data, so there's no additional reporting requirement for clinicians. The difference is that clinicians participating through an MVP will only be scored on the cost measures that are 1, within that MVP, and 2, where they meet the case minimum based on claims data. Cost measures represent the cost to Medicare for the items and services furnished to a patient during an episode. Currently, there are 2 types of measures in the cost category. The first being the global or population-based measures, which focus on broad types of care. Specifically, they focus on clinicians who provide primary care type services and who provide care in an inpatient hospital setting. And then the second type of cost measures are the episode-based cost measures, which focus on clinicians who perform specific procedures or provide care to treat or manage particular conditions or other defined types of care. Next slide, please. And so the MIPS cost performance category started with only 2 cost measures in the first year for MIPS. Since then, we have gradually added measures, including 27 episode-based cost measures, and we've completed comprehensive reevaluation for the 2 population-based measures. There are now 29 cost measures for 2024. Next slide, please. And with that, I will now turn the presentation over to Liz Peters from Acumen, who are the measure development contractor.
Thanks, Ray. My name is Liz Peters, and I work with Acumen on the cost measure development project. I'll start by providing a brief overview of the cost measure development process before diving into some of the details of the measures and the field test reports themselves. Next slide, please. So our measure development process involves gathering pretty extensive input from a wide range of interested parties to ensure that the measures are clinically valid and can meaningfully assess a clinician's cost of care. As Ray mentioned, we have been developing episode-based cost measures in cycles or waves where development activities take place on the same timeline. And so we convene expert panels called clinician expert work groups, or work groups for short, based around particular clinical topics. And so we've been convening expert panels since 2017, and we're now in wave 6 of development, which began last year. And this wave involves input from over 34 members across 35 specialty societies and organizations. But across all 6 waves of development, we've worked with hundreds of members of affiliated specialty societies, professional associations, and other organizations. Next slide, please. So throughout Wave 6, we've sought a range of input to support measure development through several different mechanisms. We have a standing technical expert panel, or TEP, that includes members from a range of clinical, academic, practice management, and patient and caregiver perspectives. The TEP provides high-level guidance for topics across the project, and specifically for the measures in Wave 6, the TEP provided input on measure construction framework for how to assess costs for chronic conditions, and which clinical topics to prioritize for development given current gaps and needs in the program. We also convene 2 clinical expert work groups, which are composed of around 15 members with experience and expertise in the area of care being measured. And they provide detailed input on every aspect of the specifications across multiple meetings. At the same time, for each measure, we sought input from 5 person and family partners, or PFPs. And these are individuals with lived experience that's relevant to each measure. They share their feedback through focus groups and interviews, and a couple of them also join work group meetings to discuss PFP findings on aspects of the measure, like who they see as being part of their care team and highlighting ways that their care experience could have been improved. So in addition to these panels, prioritization and selection of measures for Wave 6 considered feedback from prior public comment periods, such as input on candidate measure concepts, approaches to address clinical or coding challenges, and the expertise necessary for convening smaller panels that would build out the measure. So with this feedback and the combined empirical analyses and environmental scans, we worked with CMS, who confirmed the final 2 measures that we would be developing in Wave 6. Next slide, please. So here is a timeline of each stage of development for the movement disorders and non-pressure ulcers measures. The whole process spans about 18 months, starting with discussions about measure prioritization in early 2023. And since then, the work groups have met in July and September of 2023 to discuss measure scope, service assignment, exclusions, and risk adjustment. And after field testing, we'll share the feedback about the draft measure specs with the work groups again to help finalize the measures. Next slide, please. Across both measures being field tested and all of our development activities, we're guided by principles that have been defined and vetted through our technical expert panel and other stakeholders over the past several years. And these principles are really intended to hone in on the specific aspects of a measure to allow it to be effective in assessing clinician cost performance. And so the criteria are listed here. Firstly, clinicians should be able to review and readily understand measure specifications and be able to anticipate when an episode will be attributed to them. And since measures capture costs related to various aspects of clinical care, whether episode-based or population-based, it's important that the measure specifications have clinical feasibility and are consistent with practice standards. The measure should also include costs of care that relate to the clinician's role for the particular measure focus. This is important so that the measure can be used to convey information that clinicians can then use to influence costs and improve their performance on the measure. And sometimes the set of services in a measure could be broad to reflect a broader clinician role, while other times it could be more specific to a defined procedure. One related consideration is that the measure should include services where there is sufficient variation in being able to distinguish between good and poor performance. And finally, on a practical note, the measure specifications need to allow for consistent calculation and reproducibility using Medicare data. By having a general framework for cost measurement, it helps to ensure that the measures follow these principles while also being flexible enough to create measures for the care of each condition, procedure, or setting being assessed for that specific measure. Next slide, please. Next slide. Okay, great. So I'll walk through the construction of the measures now. The measures share a similar construction methodology that are focused on capturing the role of clinicians in providing outpatient management of a specific condition. And so this kind of lists out each of the steps of the measure construction, but we'll go through them specifically in the following slides. Next slide, please. So first, we identify the patient cohort by looking for a combination of services and diagnoses that indicate the start of a clinician-patient relationship focused on a particular type of care. And we do this by looking for a pair of services billed by the same clinician group, or TIN, within 180 days of each other. These services represent the care for the specific condition, and they include evaluation and management, or E&M services, and also condition-specific services. So for instance, certain types of wound care for non-pressure ulcers medicine. And so services need to be paired with a relevant diagnosis code to make sure that we're capturing the care relationship that we intend to. Next slide, please. Because chronic conditions are by nature ongoing, we identify the total length of a clinician-patient relationship by looking for additional services that indicate a continuing relationship. And so the trigger event opens basically an attribution window, and this can be extended if we see a claim that reaffirms continuing care. And so for these measures, the window is 365 days. And if there are multiple reaffirming claims, as you can kind of see in this figure here, each will have the effect of extending the total attribution window. Next slide. We define an episode as a set period of time during which cost can be assessed and then attributed in the study period in which it is. And so this episode forms a unit that allows us to examine costs and compare clinician performance. For greater granularity, episodes can be stratified into a set of mutually exclusive and exhaustive patient cohorts that we call subgroups. And this stratification basically allows the measure to focus on more homogeneous clinical groups within the overall patient cohort if applicable. And so this technique is something that we use in both of the measures for more meaningful comparisons. So for instance, the movement disorders measure is subgrouped by condition type. Next slide, please. The fourth step is attribution. So it's pretty tightly linked to the trigger and confirming services because it's those services that allow clinicians to know when they could be held accountable for care. And since MIPS has participation options at the group and individual level, the measure has attribution rules for both forms of participation, but clinicians pretty overwhelmingly participate in MIPS as groups. So the TIN level cost measures are the ones that are mostly used. And for the TIN level measure, we attribute the episode to the TIN or clinician group that provided the initial set of services that indicate the start of that clinician-patient relationship. Next slide, please. For clinicians that participate as individuals, there is a TIN and PI level measure. And so within a TIN that's attributed the measure, an episode is attributed to any TIN and PI or individual clinician that billed 30% of the trigger and confirming claims. And that's basically to ensure that the attributed clinicians are actually involved in the patient's care. So in the diagram, we kind of demonstrate how clinicians within a TIN are attributed an episode while others are not, based on the share of services that they bill. And there are some additional checks that we do to make sure that the attribution is identifying the role of the individual clinician, including checking that they either provided the initial trigger service or that they had seen the patient prior to the episode start. Next slide. Now that we've identified the patient cohort, identified the responsible or attributed clinician, and also the period of time when care is being assessed, we can look at the specific services that are included in the measure. And only services that are clinically related to the care are included in the measure, as kind of helped identified by discussions with the clinical expert work group. And so this means that we gather a lot of expert and PFE input to help identify which services are those for which a clinician can be reasonably or can reasonably influence the occurrence, intensity, or frequency. And so in this example, the diagram shows the services that a patient receives. Above the line are services by the attributed TIN, and below the line are services from other providers. The services that are in black are included in the measure, and then the services that are in gray reflect care for services that are not clinically related to non-pressure ulcers. So in black, you can kind of see that they reflect non-pressure ulcer related care, such as E&Ms, wound debridement, prescription medications, and complications like amputations. Whereas in the gray, you can kind of see that they could represent anything that's not related. So in this case, a colonoscopy or an eye exam. We use standardized Part A and B costs, which remove variation in payment that's not due to clinician care choices. And for all measures being field tested, they do include Part D costs. The guidance that we've heard from RTEP is that Part D can be included when they make up a large share of costs and where including them is necessary to fully understand the clinician's performance. And so the work groups for these measures recommended the inclusion of Part D costs based on this guidance. Since not all patients have Part D coverage, the measure further stratifies or subgroups episodes based on Part D enrollment. And so that basically means that episodes for patients with Part D costs are only compared to other episodes with Part D costs. And Part D costs are also standardized. We calculate the standardized observed cost as a scaled figure since episodes can be different lengths. And depending whether and if so, when we see evidence of a continuing care relationship. Next slide, please. So next we apply exclusions to remove certain episodes from measure calculation. These exclusions ensure that we have complete data for each episode and remove episodes that are so different that they can't be adequately accounted for through other techniques. And after that, we calculate the expected cost for episodes by applying a risk adjustment model separately for each subgroup and Part D enrollment combination. This model adjusts for factors outside the clinician's control that can affect the cost of care, such as pre-existing health conditions. And so risk adjustment ensures that providers are not penalized for treating more complex patients. Next slide, please. Finally, we take the observed over expected cost of each episode and then average that across all episodes attributed to a clinician to generate the measure score. This is a weighted average to take into account longer episodes. We then multiply this weighted average across the ratio by the national average observed episode cost to generate a dollar figure. Next slide, please. So now that we've covered the measure construction, we'll talk a little bit about the specific measures that are being field tested. Next slide. We'll start with the movement disorders measure, which assesses costs associated with the ongoing treatment and management of Parkinson's and related conditions, multiple sclerosis or MS, and amyotrophic lateral sclerosis or ALS. And so this measure was selected for development because it impacts a large number of patients and there are opportunities for improvement, such as the high costs associated with fall-related treatment. The most frequently attributed specialty is neurology, whose clinicians are currently limited to being assessed by the inpatient stroke episode-based cost measure and MSPB clinician. And so this measure may be more related to the types of care certain neurologists provide. Next slide, please. The measure includes services related to the care of movement disorders, such as routine office visits, imaging services, various forms of therapy and necessary DME, Part D medications, and related equipment, potential related infections or injuries, and fall-related care, And also emergency department visits or hospitalizations and subsequent post-acute care or home health related services that come after that. Next slide, please. To account for the variation in care required, depending on the type of movement disorder, the measure is stratified into 3 subgroups for ALS, MS, and Parkinson's and related conditions. The measure also risk adjusts for patient factors that might impact the cost of care but are outside the clinician's influence, as we kind of talked about during the construction section. The measure includes CMS's standard hierarchical condition categories, or HCCs, and it also includes measure-specific risk adjusters that have been identified by the clinician expert work group and PFP input. And so some of these include frailty, wheelchair dependence, history of falling, cognitive status, or degenerative diseases, but you can kind of see the full list. And we also exclude any episodes that can't be reliably predicted by the regression model. Next slide. Next up, we have the non-pressure ulcers measure. This measure assesses the cost of treating and managing non-pressure ulcers and was selected for development because it captures over 300,000 patients and reflects an area with high Medicare spending. And there are also opportunities for improvement that have been identified related to wound care and consequences of care. So this measure helps fill a gap because there currently aren't any episode-based cost measures in MIPS for podiatrists, which make up the majority of the attributed clinicians for this measure, alongside other specialties reflecting the role of primary care clinicians in managing non-pressure ulcers. Next slide. This measure includes services related to the care of non-pressure ulcers, such as outpatient services, inpatient hospitalization services, related procedures, such as vascular procedures, skin grafts, and as well as Part B and D medications, emergency department care, and any relevant DME and supplies. Next slide, please. Similarly to the movement disorders measure, non-pressure ulcers also is stratified into subgroups. And so there are 5 subgroups that are based on ulcer type to account for the variation in patient heterogeneity and costs. And the measure also risk adjusts for the standard set of HCC variables, as well as specific risk adjusters for this measure, which were identified by the work group, smoking and frailty. Next slide, please. So we'll now talk about how to participate in field testing. The purpose of field testing is for all interested parties to share their input on the draft measures while they're still in development. This is a crucial step in making sure that we develop as strong and clinically valid measures as possible, because we're able to use this feedback to make refinements to the draft specifications. And so we provide a wide range of materials to inform your feedback. Eligible clinicians and clinician groups can access confidential field test reports to see how they would perform under a measure, and anyone can review measure specifications, testing results, and general resources. We'll consider any feedback and share this with the work groups when discussing ways to then further refine the measures. And so the following slides will kind of walk through some of these materials. Next slide. Field test reports are available for download on the QPP website for clinicians and clinician groups who've been attributed at least 20 episodes for at least one of the measures. There's a total of about 7,200 clinician groups and 7,200 clinicians that will receive at least one field test report during this period. And so there's a separate field test report for each measure that you meet the minimum number of episodes for. So it's possible that you might receive more than one specific report. And if you need guidance on how to access the field test report, there is a user access guide that's available on the cost measures information page. There's also a mock report available for stakeholders who didn't receive a field test report that we'll be able to walk through in a little bit. Next slide. We've also posted draft specifications, and these include measure methodology, which explain the measure construction, and the codes list, which detail the medical codes used to construct each element of the measure. Elements include triggers, subgroups, attributable specialties, assigned services, risk adjusters, and exclusions. And we also have a document that lists out the set of questions for each measure, which basically is a starting point for folks to review when they're thinking through the specifications, especially if you don't want to click through the surveys. However, you, as Ray mentioned, can provide feedback on any aspect of the measure. Next slide. There is supplemental documentation that you can also review. This includes testing results such as descriptive statistics about the measure scores, breakdowns by provider characteristics, services that are driving costs, and an examination of episode exclusions. And there's also a summary of the measure development process for Wave 6 and an overall FAQ document. Next slide. So you can provide feedback on the draft measure specifications through February 29th through the online survey listed here. And when submitting your feedback, you can attach a PDF or Word document if you prefer to submit a full comment letter instead of providing responses to each survey questions. And comments can also be submitted anonymously if preferred. Next slide. So now that we've talked through the field testing process, let me just provide a little bit of detail on the information that's available in the reports, and we can walk through an example. The field test reports are intended to provide information about how you might have performed on the measure as it's currently specified, and it has 3 components: a PDF report, a CSV episode level file, and then the data dictionary. Next slide, please. The 4 different sections that are in your PDF report include your measure score, a breakdown of cost measure performance, your episode cost, and then some additional information, including appendices and a glossary for terms that are throughout the report. Whereas the CSV episode data file includes information that identifies episode and patient level information, as well as sources of episode cost. So now we'll take a few minutes to demonstrate navigating through your report and some supplemental materials by providing a walkthrough. I am going to take over screen share for a moment. Okay, so first we're going to pull up a PDF report, as this is where most clinicians who receive a report will begin when participating in field testing. And you can do this by navigating to the QPP website and logging in, as we kind of have demonstrated here. If you're unsure of how to access your report, we recommend navigating to the cost measures information page and pulling up the user access guide for detailed steps. Here you can kind of see this is the cost measure information page that we have been referencing throughout this presentation. And here is the user access guide that we mentioned. So when you log in and you access your report, basically you'll download a zip file, which we will pull up now so you can get a sense of what that looks like. And it will show the 3 different files that you have access to, as we mentioned. You'll then select your PDF report and begin viewing there. So this is an example of what that report looks like. Section 1, your measure score, first provides a high-level summary of the movement disorders cost measure. So here you can kind of see this overview. And then Table 1 demonstrates the cost of services that you provided and how you compare with other TINs. So it shows your measure score, which represents your average risk-adjusted cost to Medicare across all your episodes. And here, a lower score is better, so you can compare your score to the national average and to your TINS score percentile, which basically indicates the percentile of your performance among all TINs nationally. So for example, if your cost measure score percentile is in the 40th percentile, then that means that your cost measure score was higher than the scores for 40% of TINs nationally and lower than the scores for 60% of all TINs. And then you can use this to get a baseline of your resource use compared to your peers. There's also a full national distribution of all TINs measure scores. that met the case minimum for your reference here. Next up, we have the breakdown of cost measure performance, and it provides information on the different ways of characterizing what types of costs are included in the measure. So the first table is a breakdown of the episode subgroups, and it just represents your counts and share of episodes as well as your performance for each subgroup. Next up, we have the utilization and cost of different types of services. So this section, again, just kind of characterizes what types of costs are included in the measure. And here's kind of an overview of what this data really represents. And here in Table 3, you see the breakdown of these different categories that are identified through the restructured BETOS system or RBCS system. And it's just basically ways to classify different services. And the categories show how often your episodes have particular services, and kind of allows you to compare this to the national average and to TINs within your risk score bracket, which is basically the TINs with a similar case mix and complexity. So you can, again, kind of compare yourself to your peers and see how you're doing. We also have a table here that shows the clinicians who contributed the most Part B physician supplier costs to your episode, both inside your TIN and outside your TIN. Next up, we have the episode cost, which provides a distribution of your episode costs, and is basically intended to indicate on average how expensive your episodes are expected to be relative to other TIN episodes, as predicted through the risk adjustment model. And again, there's the national distribution below. And then the report kind of points you to the episode level file, which is where you can go look next. One other thing we just wanted to demonstrate is that if you have any confusion about maybe what's included in the table, you can jump to the glossary and jump back to help kind of get the terms defined for you as you're looking through. So that's all available at the end. And so next up, you would move to your CSV file. And this is obviously a mock report, so there's no specific data in here. But each of these columns represent a different piece of information that's included. And if you have any questions about kind of what these variables mean or what's being displayed here, you can navigate to the data dictionary, which basically just defines each of these variables and tells you a little bit about what metric is being included and kind of what it's showing. Additionally, if you have any questions as you're kind of going through this process, or you want to get a better sense of what's really being included in the measure, you can always navigate back to the cost measures information page, where you can take a look at the specifications of the measures. So just to kind of demonstrate what that might look like, if you clicked on this zip file, you would download the zip file. This is what that looks like. And you can select to look at the measure information form or the codes list for more information. And so when you look at the measure information form for the movement disorders, it provides a lot of information about the construction of the measure and the methodology. But a particularly helpful resource is in section 3, and it's a quick reference. It provides a really nice overview of all of the specifications of the measure, and is a really great starting point if you want to get kind of a quick look at what's included in the measure. If you want more details, you can then navigate to the codes list, which shows a lot of more detailed information about the different codes that are specifically included in the measure. All of the different services that are included for parts A and B and D. And so this can really give you a more in-depth look. And then ultimately, when you're ready, you can navigate back to the cost measures information page or any of the outreach that we've sent you and take a look at the survey and begin kind of providing your feedback through this process. Great. I think that we can move back to the presentation.
All right, thanks, Liz. So we're now going to start the Q&A portion of the webinar. As a reminder, you can ask questions via the Q&A box or through the webinar audio. If you would like to ask a question via the webinar audio, please raise your hand and we will unmute your line so that you can speak. To submit a question anonymously via the Q&A box, please click Send Anonymously. Otherwise, all attendees will be able to view your question. We currently do not have any questions in the Q&A box, so if anyone has a question that they would like to ask over the phone, please go ahead and raise your hand and we will unmute your line so you can ask your question. Alternatively, if you do not want to ask your question out loud and you would like to ask it anonymously in the Q&A box, you are more than welcome to do so by typing in your question and hitting Ask Anonymously. As a reminder, we will be taking questions about field testing. If you have other MIPS related questions, please contact the QPP help desk. We still do not have any questions in the queue, so just wanted to do a final round and give folks a chance to either raise a hand to ask your questions out loud or type your question into the Q&A box so that we can read it out for our subject matter experts to answer for you. All right, seeing that we have no questions, we are going to go ahead and conclude the Q&A portion of the webinar. So we'll turn it back over to Liz to conclude the call. Liz?
Thanks very much. Thanks everyone for joining. As we mentioned, the field testing materials and resources will be available on the cost measures information page, or not will, they are actively available on the cost measures information page. That page is listed here, as well as some other helpful links that we talked about today. And if you do have any other questions that come up about the information that we reviewed today, please feel free to direct your questions to the QPP Service Center, which can be contacted here. We would appreciate if you could submit any feedback that you have by February 29th. Thank you all for joining us, and we look forward to hearing your feedback during field testing.